My name is Gavin Caperton.
And I'm Ernesto. And today we had Mike, a 25-year-old mechanic, come to our clinic. He was complaining of pain along the ulnar aspect of his right wrist. He likes to play pickup basketball, and he fell on an outstretched hand at his last basketball game and reported pain in his wrist after. The following day at work, he was reporting pain and clicking at work with tasks involving ulnar deviation. Upon inspection, the area between his pisiform and the ulnar styloid process was slightly swollen and tender to palpation. We ran through some special tests and some manual muscle tests, and he tested positive for the TFCC stress test, the piano key test, Sharpie's test, TFCC compression, and the press test. When comparing bilaterally between his extension and flexion, his extension was markedly a little more painful when it came to the manual muscle test, and it was a little lower when we tried to have him conduct an active range of motion. When we tested his ulnar deviation and radial deviation, he experienced more pain when the TFCC structure was compressed, and so he was only able to get 3 out of 5 when it came to the manual muscle test, and he only achieved 20 degrees of range of motion in ulnar deviation compared to his left. Pronation and supination also were only capable to achieve through pain, but those were a little stronger, and there were more active range of motion deficits in those as well.
So, some basic information about the TFCC lesions. So the TFCC is a major ligamentous stabilizer of the distal radial ulnar joint as well as the ulnar carpus. So the entire TFCC is going to be located between the ulna and these two cockle bones, the lunate and the triquetrum. So TFCC kind of acts as a meniscus in the fact that it aids in transmitting forces directed towards the ulnar side of the wrist. So typically this injury will present with ulnar side wrist pain, and you will also typically hear clicking. So pain will worsen with forearm rotation as well as ulnar directed movements. So this injury is typically diagnosed using x-rays or MRIs as well as many special tests. So some sort of precautions to take for the patient. So we'll have Mike, he'll be encouraged to avoid all aggravating activities such as repetitive hand motions like ringing, turning and twisting movements, or lifting heavy objects and holding onto those heavy objects. The patient will also be advised to try to keep their wrist in line with their forearm.
And so since Mike is a younger individual, we decided to go with the non-operative plan where he will have to splint for 4 to 6 weeks. And since there are no pain and symptoms following the splinting, that is indicative of following the conservative progression. So for our progression, we're going to start by progressing through range of motion exercises from passive range of motion through the active assisted range of motion if necessary, and active range of motion. The progressive strength model is going to follow isometrics into uniplanar and multiplanar exercises, which will also be incorporating proprioception and other aspects of his therapy.
So we will start in with range of motion exercises. We'll start with forearm pronation and supination, wrist flexion extension, ulnar and radial deviation, clockwise and counterclockwise movements at the wrist, as well as passive finger stretching. So as we get on to the strengthening and some more proprioception exercises, we will start them off using physician facilitated eccentric flexion, extension, and deviation. We will use finger abduction and abduction, as well as flexion, extension, and ulnar and radial deviation using a TheraBand. We will do grip strength exercises with an elastic putty that we can increase the elasticity of as we progress them. We will also do wrist rotation with a weight, as well as rolling the ball on the wall, catching and throwing the ball, and the pegboard exercises. Those 3 will be more geared towards his proprioception. And as some functional exercises, we will have him tighten and loosening bolts, because as Mike is a mechanic, that is something that is very vital to him being successful in the workplace. And we also have him performing a deadlift and carrying an object such as a toolbox, something that he will also need to be able to perform on a daily basis.
So when comparing the non-operative plan to the operative plan, the main difference is really just going to be that following the splinting, which both of the processes will have to follow, the TFCC will have to be debrided, and so they'll have to go in through with an arthroscope and clean out the tissue that has been frayed. And so here we have an example of different types of lesions. And so during the part where you can see the frayed edges, they'll go in with the shaver and clean out those ends and just make it a more congruent surface. Most of the TSCC is generally a vascular portion, so if we do get a tear into a part that is vascular, that is something that the surgeons can go in and suture down into the fovea and make that joint a little more congruent and make it a little more acceptable to the carpal bones. So when we compared non-operative to operative and made our decision, the non-operative course is the initial treatment that you generally follow for all TSCC injuries. It is after you do the splinting for 4 to 6 weeks where you kind of decide whether you decide to follow the conservative program or go operative. So since Mike wasn't displaying any pain or swelling following the splinting, we followed the non-operative plan, which is not particularly useful for chronic injuries anyway. So since he did receive his mechanism of injury was acute, we were more geared to following the non-operative plan, which does not involve any incision or wounds and does have a shorter rehab time since there is no operation necessary. Both of the operative and non-operative follow the same exercise and range of motion progressions. It is just with the non-operative that you can begin those exercises earlier. So with the operative, it is really only more indicated in patients with chronic pain or that are older. Most of the tissue is avascular, so kind of shaving it down heals, increases the healing time for the wound before you can begin therapy, but it does produce better results in the long run.
So a few examples of the range of motion exercises that our patient will be performing. The first one of which is forearm pronation and supination. So our patient will be standing with his elbow at 90 degrees and he will be pronating and supinating his wrist at a nice slow rate, holding in the pronation or the supination for 3 to 5 seconds before slowly going into the next one. Another exercise we'll have him doing is wrist flexion and extension. So there's many different ways to do this one. So you can do it the same way, have him standing, elbows at 90 degrees, working on that wrist flexion and extension. Another example of that wrist flexion and extension is using a table sort of as an A. So we can have him kind of putting his weight on his hands right there to get into wrist extension, and you can do the exact same thing as well to get into wrist flexion. We also have him working on ulnar and radial deviation, same thing, elbow at 90 degrees, have him ulnar deviate. This one's especially important, this one that would typically produce pain, so have him ulnar deviate and radial deviate. And that would conclude just a few of the range of motion exercises. So next we'll be demonstrating a few of the exercises for strength and proprioception that Mike will be performing during his rehabilitation plan. We will start with the eccentric movements of the wrist. So we'd have the patient stabilizing his distal forearm. We'd have him already in extension and then have him resisting the applied pressure, taking him slowly eccentrically out of that wrist extension. You could also do that for flexion and deviation. The next exercise that we will be demonstrating is weighted wrist rotations. So as we talked about earlier, we'd have his elbow at 90 degrees and we'd have him slowly pronating and supinating with that weight in his hand. So a proprioceptive exercise that we would have Mike perform would be rolling the ball on the table, having to make those small circular movements. And we could also progress him to doing that on the wall, kind of changing that distribution of the pressure on the wrist, working on his proprioception, as well as tossing and catching a ball. So we instruct him, we start with the underhand toss, making sure he's getting good wrist flexion and extension when tossing. Also have him catching, working on that hand-eye coordination and proprioception, and progress him to maybe an overhead toss, once again still focusing on that wrist flexion and extension. So a few of the functional exercises that we will have him doing is so tightening and loosening a bolt. So we'd have a bolt and we'd actually have him tighten it and loosen it. And we'd also talk about the proper biomechanics of lifting something and carrying it. So if this was a toolbox, we'd have him lift it and carry it to wherever else, instructing him to try to keep that wrist in line with the forearm as often as possible.